Hello, everyone, and welcome to the first grand rounds of 2024 for the SSAT Complex GI Surgery Fellowships. My name is Annie Benzie. I'm the chair of this subcommittee and I'd like to welcome everyone this evening. We are sure to have a great and a very timely talk tonight presented by our fellow. And I would also like to introduce our moderator extraordinaire of the evening, Dr. Ranjan Sudan. He is a bariatric surgeon and professor of surgery as well as psychiatry at Duke University School of Medicine and our current SSAT vice president. So welcome, Dr. Sudan, and welcome to everyone.
Well, thank you. And before I introduce Dr. Sohail, I just wanted to say a couple of words. In addition, my area of expertise certainly is bariatric and revisional bariatric surgery. And I do a lot of robotic surgery and actually described the first duodenal switch that was performed robotically back in 2000. So while this is going to focus on the non-surgical aspects of it, I just wanted to give people a sense of my background and that I do all of the various operations. And it's my immense pleasure to introduce Dr. Sarah Sohail. She's a complex GI fellow at Banner Gateway and Estrella Medical Center. And she completed her surgical residency in Tucson. So she's currently in Phoenix. So welcome, Dr. Sohail, and we look forward to your talk in this very timely and new frontier topic, GLP-1 receptor agonists.
Perfect. Thank you for the introduction. I am a complex GI fellow, but we do quite a bit of bariatrics as well in our practice and in my fellowship. And one of the things we've been doing a lot of since I started is using GLP-1 receptor agonists as adjuncts to bariatric surgery. So I just wanted to kind of enlighten everybody on what's going on in that field and how we've been using it. So disclosures, I have none. A little bit of background. So as we all know, obesity has been a rising epidemic globally and within the US within the last few decades. It is now considered a public health crisis. The annual cost of managing obesity in the United States is $190 billion per year, which is approximately 20% of the total national healthcare dollars. Patients with severe obesity, which is defined as a BMI of over 40, have a 6 to 12-fold increase in all-cause mortality, and their life expectancy can be reduced by up to 20 years. So there's a lot of incentive to treating this disease process in multimodal fashion. There's a lot to be gained from this. So currently, bariatric surgery is the most effective treatment for obesity. It does have its limitations. It is surgery requiring general anesthesia. All patients with obesity may not be candidates for something so invasive. And we do see complications from it. We do see weight recurrence, which has kind of opened the avenue for looking into anti-obesity medications and whether they can augment or even eventually replace bariatric surgery. GLP-1 receptor agonists have been on the forefront of the anti-obesity medications in the last couple of years, and they've been showing a lot of value when used synergistically with surgery. So which medications are we talking about? So under the GLP-1 receptor agonists category, there are 3 that have been FDA approved. The first is dulaglutide, that's Trulicity. It's only FDA approved for diabetes and not for weight loss. Patients may see like some modest weight loss with using it, but it's really not one of the medications that we use for that. Liraglutide was the next on the field. Victoza is the form that is approved for diabetes, and Saxenda is for weight loss. And that shows a little bit more weight loss when using that. And then semaglutide is the big one that we've all been hearing about. So that is even more effective than liraglutide. Ozempic is the subcutaneous injection approved for diabetes treatment. Rybelsus is an oral pill also for type 2 diabetes treatment. And then Wegovy is the form that is FDA approved for weight loss. And then the newest medication on the scene is a GLP-1 receptor agonist and a GIP receptor agonist, and that's tirzepatide. It's been on the market for for at least a year as Mounjaro for treating type 2 diabetes, but then in November, they got FDA approval for Zepbound, which is approved for treating obesity. So how do these medications work? In order to understand that, it's helpful to know how these hormones work. So both GLP and GIP are hormones that are changed in our body after undergoing bariatric surgery. So you can see how these medications would work kind of similarly to how bariatric surgery works. So when you eat, the amount of GLP-1 is increased in your body. It's released by ileal and colonic L cells. Your endogenous GLP-1 is broken down by DPP-4, and the GLP-1 receptor analogs like semaglutide are actually resistant to this breakdown by DPP-4. So injecting these medications increases the amount of GLP-1 and then also slows the degradation of it. This then goes and acts in the brain. It will decrease hunger, increase satiety, can also cause nausea. In the pancreas, you're going to increase your insulin release and decrease glucagon release. In the stomach, there's some evidence that there's delayed gastric emptying. And then it also acts on the fat cells themselves by decreasing inflammation and increasing lipolysis. The GIP acts very similarly, except for that's released by your duodenal K cells. And then you can see that the actions in the body are quite similar as GLP. There are a lot of landmark papers looking at these medications and seeing how they can be treated to treat or used to treat obesity. I think kind of the program that's the most relevant for this talk is the STEP program. So it started with 5 trials, and they were using semaglutide to treat obesity. The dosage that they recommend and use to treat obesity is the 2.4 milligrams. For diabetes, their max dosage is 2 milligrams. And the way they do it is they start everybody on 0.25, and then every 4 weeks, they increase the dose until you reach the max dose and continue patients on that. So for the STEP 1 trial, they looked at patients with obesity, so BMI greater than 40, and they treated them with semaglutide for 68 weeks. On STEP 2, they repeated the same trial, but they used patients that had obesity and type 2 diabetes. In STEP 3, they kind of repeated STEP 1, except for this time they combined the use of semaglutide with intensive behavior therapy, which included food logging, dietary changes, and physical activity. And then STEP 4 was their sustained weight loss trial. So after 20 weeks, they switched half the patients to placebo, continued the other half on semaglutide. And they saw that the ones that were switched to placebo did start to gain that weight back. And then STEP 5 just showed efficacy over a 2-year period. So they continued those patients for a 2-year period and saw continued sustained weight loss. From all of these, the average weight loss that patients were seeing at 68 weeks was about 16% of their total body weight. They then went on to do more steps. I think they're up to step 8. And one of those included comparing it to liraglutide, which did show that semaglutide is much more effective than liraglutide in terms of weight loss. So this chart just charts out all of those medications and compared with surgery for how much weight loss can be accomplished with these. So there's the oral anti-obesity medications, which includes what we've traditionally used, things like phentermine, topiramate, naltrexone, and they achieve about 5 to 10% excess body weight loss. And then liraglutide, which was the kind of first one we tried, can achieve about 8%. Semaglutide, they see the maximum at almost 16% of your total body weight loss. And then tirzepatide, which is the GLP-1 and the GIP receptor agonist, and has the best results, and that can lead to 20 to 25% of your total body weight loss. So it's very promising data. Surgery obviously is still much more effective. With a sleeve gastrectomy, you can see 50 to 70% of your excess body weight loss. Roux-en-Y gastric bypass will be 60 to 75, and then duodenal switch is the most effective, and that's 70 to 80%. There are added benefits to using GLP-1 receptor agonists besides just treating the obesity and the diabetes. They have been shown to help improve and even resolve NASH in certain patients, and they can halt the liver fibrosis. They can lower the risk of cardiovascular disease in both diabetic and non-diabetic patients. The big clinical trial that proved this was SUSTAIN-6. They studied 3,000 patients with type 2 diabetes and started them on either semaglutide or a placebo. They found that fatal cardiac events occurred in only 6.6% of the patients treated with semaglutide, compared to 8.9% of patients in the placebo group. And then they also found a reduction in the rate of non-fatal stroke, new or worsening nephropathy. And then they did show a little bit of a worsening in patients with diabetic retinopathy, and we'll talk about that a little bit down the line. There's ongoing research to see whether the use of semaglutide may have a role in treating patients with heart failure with preserved ejection fraction and may be protective against worsening heart failure. And then further research is also being done on the effects of renal protection in patients with CKD. So the indications for using these medications is obesity, the BMI of over 30, or pre-obesity, which would be a BMI of over 27 with at least one obesity-related comorbidity. That can include sleep apnea, diabetes, hypertension, hyperlipidemia. The contraindications, there aren't too many. The biggest ones are personal or family history of MEN2 or medullary thyroid cancer, because there is some risk of these medications causing progression to medullary thyroid cancer. It cannot be used in pregnant patients, and then don't use it for anyone who has a hypersensitivity to the drug. The relative contraindications or kind of cautions to be aware of, pancreatitis. Pancreatitis is a rare side effect of using GLP-1 receptor agonists, but it can happen. So if they develop pancreatitis on the medication, it should be stopped. Gastroparesis. So if the patient already has gastroparesis or delayed gastric emptying, this may not be a good medication to start them on, as it may cause some additional delayed gastric emptying. Use caution if the patients are already on insulin or sulfonylureas, because when it combined with those medications, it increases the risk of hypoglycemia, although when used alone, there is no risk of hypoglycemia with semaglutide. And then diabetic retinopathy is shown, it can worsen when patients are started on semaglutide, and that's due to the rapid correction of hyperglycemia, can worsen the retinopathy. So you just got to watch for that. So the biggest adverse effects, so the big thing that all our patients want to know is what's going to happen when I start this medication. The most common things they complain about is going to be GI side effects. So nausea and vomiting, diarrhea, or constipation and abdominal pain are kind of what we hear all the time. These side effects are worse when you're first starting the medication or when you first go up on the dose. The ways that we recommend our patients mitigate these, especially the nausea and vomiting, is eat smaller meals, smaller, more frequent meals, skip a meal if you have to, make sure you're getting at least 64 ounces of water, and avoid any trigger food, which tends to be like fatty foods or dairy. The pancreatitis we spoke about, it can cause pancreatitis, although it's very rare. The medication should be stopped if a patient develops pancreatitis. And then delayed gastric emptying, I put a question mark there. So I think that's kind of one of the hot topics right now, where a lot of people are concerned that it's causing delayed gastric emptying or gastroparesis, leading to increased aspiration events. There is no good data suggesting a causative effect between the GLP-1 receptor agonists and delayed gastric emptying. There's a lot of case reports and kind of single reports saying that patients had food in their stomach when they were scoped, or maybe like a couple episodes of aspiration on induction of anesthesia. But a lot of the patients that have been started on this medication are diabetic and have other risk factors for developing gastroparesis as well. So I think that we just need to do a little more research into that and see whether there is a direct relationship or not. The American Association of Anesthesiology does recommend holding any GLP-1 receptor agonists for a week prior to receiving any general anesthesia. And that's the policy at our hospital as well. We have our patients hold it for a week. Okay, so before diving into the use of these injectable weight loss medications, in conjunction with surgery, I wanted to look at what research we've already done or what we've already tried in terms of using medications to help augment bariatric surgery. So this paper from 2022 out of West Virginia was a retrospective review looking at patients who either received preoperative pharmacotherapy if their BMI was over 60, or if they received it during their first 2 years post-op for inadequate weight loss or recurrence of any comorbidities. And in their study, 94.1% of patients underwent a sleeve gastrectomy, 5.9% had a gastric bypass. The medication they used on all patients here was phentermine, plus or minus topiramate. And then when they looked at the 1-year data, the weight loss in patients who received the pre-op medications was 31.3%. The patients who just got it at 1 year post-op was 25.3%, and then the patients that got no meds at all was 20.8%. So you can see kind of an increasing amount of weight loss based on when you start the medication. And then when they compared this with the MBSA-QIP data, patients getting anti-obesity medication starting in the preoperative period weighed 2.4% less than expected for the national average. So you can see that there's definitely a benefit for treating patients even preoperatively in order to help them achieve their weight loss goals. So neoadjuvant GLP-1 receptor agonist treatment. So this is giving them the medication prior to surgery. The rationale for doing so is, one, to reduce operative risks in patients with a high BMI. And then also, like we talked about in the last study, to increase the likelihood of patients reaching their weight loss goals. I know that preoperative weight loss goals or mandates have been kind of done away with, mostly in bariatric surgery. Traditionally, insurance companies would, demand a certain amount of weight loss, and that was shown to just delay people's surgery or kind of discourage them. The ASMBS did release a position statement in 2021 saying that they do still recommend at least a preoperative diet that's going to assist in reducing visceral fat and decreasing the liver size, which will help reduce the 30-day mortality. So there is a benefit, although we don't give our patients a number, like a weight they have to achieve or a BMI they have to achieve. The more you can help them get their body weight down, the safer the operation will be for them. A lot of the data on using neoadjuvant GLP-1 is very fresh. It's a lot of retrospective data. People are just kind of starting to do this, so we don't have a ton yet. This is one paper we found from the University of Oklahoma. Basically, any patient coming through their program with a BMI of greater than 50 were prescribed a GLP-1 receptor agonist. However, they only included 31 patients in their study because they were not able to get insurance coverage or find availability for most of these medications. They found that the mean weight loss was 16.7 kilograms versus 8.2 kilograms in the group that got the GLP-1 receptor agonist, and the decrease in BMI was about 5.5 compared to 2.9. And they found no GLP-related complications seen perioperatively, and that was primarily looking at aspiration events. So for post-operative GLP-1 receptor agonists, this is something that people have been doing a little bit longer, and this is using the medication as kind of a rescue for patients who are seeing weight recurrence. So depending on the definition you look at, up to 37% of bariatric patients may experience weight recurrence or return of comorbidities after bariatric surgery. Traditionally, you can offer revisional surgery, but this is obviously associated with increased morbidity from the primary surgery because you're reoperating in that field. And the results can be inconsistent with unpredictable rates of weight loss that are not going to be as high as with the primary surgery. So there was the Gravitas trial in 2019, which showed that patients could receive a mean weight loss of 4.2 kilograms after receiving liraglutide, compared to receiving a placebo after bariatric surgery. And that's liraglutide, so I think with semaglutide, it could be almost double that. There's another retrospective study from Germany from 2022, which showed that patients with weight recurrence started on semaglutide lost about 10% of their total body weight. And then there was an additional study from Switzerland published in 2022, which showed that patients after bariatric surgery who were on a GLP-1 receptor agonist for 6 months could lose an average of 67.5% of their regained weight for being on that medication. For anyone who's in the field of bariatrics, they know that these patients that are facing weight recurrence tend to be kind of a challenging patient group. They're often pretty down on themselves and feel frustrated with the program and frustrated with the weight recurrence. So I think having this option there to kind of boost their weight loss and helping get them back on track can be a really, really positive thing for them. So there are some arguments against using these GLP-1 receptor agonists along with surgery. One of the questions that's out there is, does altering the levels of your GLP-1 and GIP preoperatively change how you respond and how effective the bariatric surgery will be? There's no data showing that this is true, but that's one of the concerns, is does giving this boost already preoperatively kind of lessen the boost that you get from the surgery itself? Another concern is the potential development of delayed gastric emptying, leading to increased rates of aspiration at times of surgery. Like I said, so far we haven't seen an actual increased rate of aspiration, but that's something to keep an eye on. And then another question is the weight loss secondary to GLP-1 receptor agonist causing worsening nutritional status? So the argument here is that a lot of people on this medication have no appetite, they might be nauseous all the time. And they're not eating as balanced of a meal, and they might be losing weight in more of an unhealthy way than those who are undergoing bariatric surgery. I found one study that kind of addresses that, and this is a paper out of Japan from earlier this month. And they treated patients with diabetes who had undergone a sleeve gastrectomy with semaglutide over 12 years after their surgery, if they had had any weight recurrence or diabetes recurrence. They divided those patients into a conventional diet group and then a low energy, high protein formula diet group. They saw that these patients did have a significant drop in their A1C and BMI, as a lot of these other papers have shown. But they also saw that the patients had a drop in B12, zinc, albumin, and skeletal muscle mass compared to the patients that had undergone a sleeve alone. So their concern was that the nutritional metrics were worse in patients after being treated with semaglutide. They did find that the drop was less so in the group of patients on their high protein formula diet, and that might be protective against malnutrition. I think that just highlights that these medications, anytime they are prescribed, those patients should be followed very closely by a comprehensive obesity clinic. Patients should be seen regularly, they should be seeing a dietitian, and they should be knowing how they can keep their vitamin levels and their muscle mass up by sticking to a high protein diet. And then I included a couple cases from our clinic. So the first is a 29-year-old female who arrives for initial bariatric consultation. She has a BMI of 59 and she weighs 150 kilograms, and she's interested in bariatric surgery and sleeve gastrectomy specifically. She is started preoperatively on 0.25 milligram dose of Wegovy and initiates her medically supervised weight loss. And then the way that we do our GLP-1 receptor agonists, I mentioned that the way they did in the studies is they increase the dose every 4 weeks automatically. We evaluate the patients every week. They're seen by either a dietitian or a PA. And as long as they're continuing to lose weight and have success, we keep them on the same dose. And then once they start to plateau is when we increase their dose. And that way they have a little bit more cushion for the increasing of the dose. And with them coming in so frequently, we're seeing pretty good results with weight loss still. So 6 months later, she's seen in clinic again, is on the 0.5 milligram dose of Wegovy. Her BMI is now 55 and is down to 147 kilograms, but she notes that her weight loss has kind of plateaued. So her dose is increased to the 1 milligram dose. The day of surgery, which is 10 months from her initial consult, her BMI is down to 49 and she weighs 125 kilograms. So her BMI has dropped 10 points, which is very significant in terms of looking at her 30-day morbidity. And her surgery went well. She was seen at her 2-week post-op clinic visit. Her BMI is now down to 45 and she weighs 114 kilograms. And she's been off her Wegovy since 1 week prior to surgery. We don't automatically restart the patients on it unless they may have been taking it for something else, such as like diabetes or PCOS. And she saw a 27.8% total weight loss so far. So case 2, this is a 47-year-old female with a past medical history of diabetes and obesity. Her BMI was 55 with a weight of 137 kilograms. She came in for her initial evaluation for bariatric surgery. This is in 2019 before semaglutide has been approved for obesity. At the time of surgery, her BMI is 53 with the weight of 132 kilograms. She's had a little bit of weight loss, not a ton, and she undergoes a sleeve gastrectomy. She does very well post-operatively. Her BMI drops to 39 at the 1-year mark with a weight of 96 kilograms. She still requires a little bit of insulin, but far less than she was pre-op. And then 3 years post-op, she's back in our clinic. Her BMI is now up to 45. Her weight is 112 kilograms, and she's frustrated and wants to get her weight down. So she started on the Ozempic 0.25 milligram dose. It's titrated over the next several months up to the 1 milligram dose. She's been coming in monthly for dietitian and PA visits. She's been implementing lifestyle modifications, has been food logging, and 6 months later, her BMI is down to 40 and her weight is 99 kilograms. And she's on 1 or 2 units of sliding scale insulin a day. So she is actually...
And Dr. Sohail, sorry, it's Rohan Jayaraja here. So I just wanted to stop for just a second and just maybe get some discussion. Dr. Sudhan, in this case, like, why would you not consider going to a D-switch or a gastric bypass in this patient? I'm just for discussion, wanted to ask you, because it's an interesting case. Some people believe that a sleeve is the first step to whatever you want to do next. Thoughts, Dr. Sudhan? Nice to see you, Sarah, by the way.
You're on mute, Rajan.
Thank you, Sarah. Sarah, your presentation is so awesome, and I think you've got some more slides. So I'm going to answer Rohan's question, but then I'll be happy to obviously have you continue with your presentation and even see what your own thoughts are about this. So, when you're going from a primary operation to a revision operation, typically the bar set by the insurance companies are higher. And they typically require you to demonstrate some degree of medical weight loss or some degree of compliance before they'll approve the revision operation. So while they're undergoing this reevaluation process, which, in our parlance, we call it, getting back on track. So while you're getting the patients back on track, a lot of the times we will use these medications if the patient's insurance company will cover it, to see what kind of benefits they can get. And sometimes that's all that they need. They need to get back on track with their diet and exercise, and the medications will be helpful. But obviously, as Dr. Sohail mentioned, once you come off these medications, the weight will start to come back on. And then it's a question of how long can you maintain your lifestyle without these medications versus needing additional surgery. So if you're significantly overweight, then those operations certainly, either a revision to a gastric bypass or a duodenal switch becomes an option. And there are many fine points, and I know this is a foregut fellowship, not necessarily, I mean, this is a complex GI fellowship, not necessarily a bariatric fellowship, but I'll be happy to discuss the fine points with you. So I'm going to turn it over back to you, Dr. Sohail, and see if you have any thoughts on this particular question, and then to see what additional thoughts you have on your presentation.
Yeah, absolutely. Thank you. I actually agree exactly what you said. And I think while a duodenal switch would have been another probably very effective option for this patient, I think the GLP-1 receptor agonists, I think they help put it back in the patient's court, whether they want to be more invasive and go with an operative or reoperative option versus try to implement those lifestyle changes again and use the medications to get back on track.
Thank you.
Yeah, of course. I think there's not too much more. So there are many challenges to using these medications. They sound like a slam dunk and like we should be handing them out left and right, but unfortunately, there are many things standing in our way of that, and mostly it's the insurance companies. So many of them do not cover anti-obesity medications, especially not the injectable formulas. For diabetic patients, you have to show failure of other medications first, so this can often be a process requiring several months, multiple prior authorizations for various medications before they can get approved for Mounjaro or Ozempic. Medicare does not currently pay for anti-obesity medications, which removes the incentive for private insurances to then pay for it. So then the out-of-pocket costs can be over $1,000 per month. So even when you do go through all those hoops and get the medication approved, there is a shortage in most pharmacies in the country, especially for those lower doses, the 0.25 and the 0.5 milligram doses of semaglutide. The pharmaceutical companies are currently focusing on making the higher dose pens because they want to make sure patients who have been started on the medications are able to continue up to the max dose before starting a bunch of new patients on it. And this is leading many patients to turn to buying medications from other sources. This can be online pharmacies, internationally, or other unregulated sources without medical oversight, including some, med spas or weight loss spas. These are not recommended options for patients because there's no regulation over these. They do not require a physician's prescription. You see a lot of these online advertisements of, you want Ozempic, like $50 and we'll mail it to you, no prescription needed. And we really don't know what they're selling. We've had incidents of patients coming into our clinic that are taking like research grade semaglutide that's not intended for human use. You have patients taking basically saline. So those unregulated sources we don't recommend. And then I think kind of the most controversial thing on this slide is whether or not to use compound pharmacies. So a lot of physicians feel that compounding pharmacies are just as bad as these other resources, and we shouldn't be sending patients to them because we can't regulate what they're producing. So I did a little bit more digging into how the compounding pharmacies are making this medication. And basically, when the FDA lists a medication on its short supply list, it gives compounding pharmacies permission to formulate that medication within their own pharmacy. In order to do that, they still have to get all of the active ingredients from FDA-approved manufacturers. So they are still getting like the raw semaglutide base form from an FDA-approved manufacturer. And then they are formulating basically what it's compounded with in order to give the injection. So while there's like a little bit of them coming up with their own recipe, the actual active ingredient itself is still an FDA-approved ingredient. And these compounding pharmacies, although they're not regulated by the FDA, they do have their own regulation boards, and they're regulated by various state laws. So I do think that if you have a compounding pharmacy that other physicians have been having good success with, and they've been kind of tried and true in prescribing this medication, I do think that it's a reasonable option if you have a patient that would really benefit from these medications and you're not able to get them approved traditionally through their insurance. I think it could be a good option for them, and it could be something that we can look into a little bit deeper. But I know that's a controversial take. And then looking to the future, there are many more medications in research and development targeting even more hormone receptors. On this chart here, I've included several clinical trials that'll be ending, that either just ended or will be ending within the next year. So there's going to be a lot more new drugs hitting the market, hopefully ones that are more affordable and easier to access. And they're going to be targeting various other hormonal targets and combinations of those targets. So we do anticipate a rise in anti-obesity medications, again, used either alone in place of bariatric surgery or in conjunction with bariatric surgery. Currently, and I anticipate for the next couple decades, bariatric surgery will remain the most effective tool for weight loss, and it's unlikely to be completely replaced anytime soon as a primary management. But I do think that there's a lot of changes coming on the horizon that'll be very interesting to watch. That's it. Any questions?
But Dr. Sohail, that was absolutely outstanding. And I think that there's a couple of questions in the chat. And while we visit that questions, I just wanted to make some random but interesting comments. So I don't know if you watch CNBC at all or not, but from 7 p.m. onwards, there's a show that comes on. It's primarily got to do with news. And one of the segments is random but interesting. So this is not my original. I kind of borrowed it from there. So the reason I mentioned that I do the duodenal switches in addition to the other operations is that, as you go from a sleeve gastrectomy, or really, let me back up. As you go from a band to a sleeve gastrectomy to a gastric bypass to a duodenal switch, and you look at the GI hormones that are affected, mostly what you see is that the GLP-1 levels and the PYY1 levels go up considerably as you go from, say, the non-bypass operations to the more severe bypass operations. So just, that's one random thought that people need to keep in mind, and that's really the way these GLP-1 drugs work. The other part about these GLP-1 drugs and their effect on diabetes is they did some experiments in which they really sort of annihilated the islet cells. And when they gave these rats, these are the Goto-Zaki rats, which they gave those GLP-1 analogs, it really helped reorganize their islets. And I have a presentation in which you see these before and after pictures of these organized islets, and it looks pretty amazing. So these GLP-1 drugs are really pretty remarkable in the sense that they have a really potent effect on diabetes, and they have a really potent effect on obesity, and primarily through their anorectic effect, but also maybe they slow down the gastric emptying, and that gives people more a sense of fullness as far as their stomach is concerned. So the questions, and I've got other random but interesting comments to make along the way in case we run out of questions. So the question was, higher up, would you have considered a more aggressive operation to start with other than a sleeve for a higher BMI patient? And I know there are several attendings and fellows on this call. So if there are other bariatric specialists, please feel free to chime in as well.
Yeah, of course. I think that's case 2, I believe that you guys are referring to. Well, I guess either, but especially for case 2, I think I would have been leaning towards doing a gastric bypass due to that higher BMI and the diabetes, because the gastric bypass does show a higher incidence of resolving diabetes. The best I could tell from the chart review, this patient surgery was back in 2019, was that it was just a patient preference. They just strongly wanted to undergo a sleeve just for the lower risk of long-term morbidity. But I think
that's a very good point, because patients tend to choose simpler, less complication-prone operations, and sleeve gastrectomy has the least morbidity, mortality when compared to a gastric bypass or a duodenal switch. So, from a patient standpoint, that is true, but not just from a patient standpoint, from a surgeon standpoint, that is true as well, in that they'd rather offer a less complex operation than a more complex operation. So here are some kind of interesting statistics in that about 40% of the patients who have gastric bypass eventually will regain weight to where they will need a reoperation. So that number is pretty high. For duodenal switch, that number is around 5% or so will still regain weight and will still need some other adjuncts. The initial weight loss that you expect out of a sleeve is almost as good as what you would get from a gastric bypass. So there are some reasons why you would choose gastric bypass, and you mentioned that, if a patient has diabetes, a gastric bypass is better than a sleeve, or as was mentioned here by David, especially if a patient has GERD, then a gastric bypass may be better than a sleeve. But if you're looking purely for weight loss from a high BMI perspective, obviously the duodenal switch would give you the most amount of weight loss, though it might not be appropriate in all patients just because it's a pretty severely malabsorptive operation and patients have to be prepped appropriately. So those are kind of my side comments on that.
Dr. Sulin, we have
Can I
Dr.
just make some
Matar.
comments too?
Of
Sorry, I
course,
was also
David.
going to say that you have Dr. Matar on the call too. Samar Matar, bariatric. So if you wanted to ask him some of your opinions too, please feel free.
Okay.
So first of all, I just want to say that I think not because she is our fellow, but I think she did a really good comprehensive job in presenting the topic. But one thing that I want to make very clear is the fact that we use those drugs as adjunctive treatments. We don't use the drug as an alternative to surgery. We still think surgery is the most effective in case of obesity and recurrence of that obesity. And it's sometimes, like she mentioned, hard to convince a patient to undergo more surgery in a case where they already had surgery and they want other alternatives that are less invasive. And we think that this is a good alternative when especially the patient doesn't want to undergo more surgical procedures. Although I tend to agree, either switching them to a duodenal switch or in case they have a severe reflux to a gastric bypass will be the most effective way of addressing the obesity recurrence.
Thank you, David. And Samar, I have a question for you. First of all, welcome and thank you for joining the conversation. Where have you been and how have you been using these GLP-1 analogs?
Thank you, Ranjan. It's good to see you. It's been a while. And my apologies for joining this group a little late. I just finished my clinic upstairs. To answer your question, and I'm not sure what has been presented already in this session, but the way we incorporate anti-obesity medicines in our practice is basically in all phases. It's a continuum of the care, really. We occasionally will use them in the preoperative phase when the patient needs to lose a little bit of weight. And I'm talking about patients whose BMI is above 60, for example. And we use them also after surgery in those patients who are struggling with weight recurrence, as you mentioned. And there's quite a few of those that unfortunately we see from time to time. And of course, in addition to that, there are those patients who, for some reason, either have an absolute contraindication to surgery or some other inability to advance to surgery. We have a very close relationship with our obesity medicine experts, and I like to keep it that way rather than actively prescribe these medicines. And I'd like to know your point of view in this. We did dabble into, although we all have ABOM certificates, myself and my partners, we found that when we started prescribing these medications, our staff would get inundated with calls from the patients about, do you have any coupon cards? Do you have any discounts? How do I deal with insurance? And so on and so forth. And so I was very happy to pass on these patients, refer them to my obesity medicine patients, because they basically have the structure, the infrastructure to deal with all these peripheral things. Long way of answering your question, but I don't know if I answered it appropriately or not.
Of course you did. And, we have a very similar approach in that we will prescribe weight loss medications through our PAs, but for those patients who are interested in surgery. And so, Samar, just to sort of crystallize what you were saying, and I'm sort of repeating what you're saying, we use it preoperatively in very high BMI patients as a risk reduction technique to try to get them to a more reasonable weight loss, more reasonable weight category. So somebody comes in 650, 700 pounds, we'll typically start them on weight loss medications. The other group that we will start weight loss medications as part of our practice is the revision patients. And, certainly while they're undergoing this or getting back on track, so to speak, with their diet and nutrition. And this is particularly true for sleep patients, assuming that they're able to get these medications. Sleep patients, and some of these sleep patients, they carry other comorbidities, or they got to sleep because they were, say, transplant patients, and they don't want their transplant medication absorption messed up by all of the various bypasses that we will do, etc. So for some people where we consider switching them or revising them from a sleeve to another operation may not be in their best interest, we'll use weight loss medications in those categories. And then there's this third category, which is a very interesting category, which may be impacting one of our practices.
Que están de largo hablando acerca de los.
Can everyone just put themselves on mute, please? Thanks.
Thank you, Annie. So there's this other third category, which is very interesting, and I'd like people's perspectives on it, which is the people who used to either get a lap band or get a balloon. Now they're getting pretty good weight loss with these weight loss medications. And so it's sort of eliminating this whole category of people who sort of want weight loss, but don't want the severe operations. And the less severe operations that were available are sort of getting wiped out by these medications. So what are your thoughts on practice, or how are these medications impacting your practices?
We've seen a lot of patients who had bands placed, and most of them, we talk to them and they understand the need to remove that band a lot of times and move on into something else, either a bypass or a sleeve. But some of those patients, they really are adamant about not having more surgery. And I don't see a problem in using their band in order to create somewhat of a less of a restriction, just as a reminder that there is a mechanical obstruction there. And the use of the medication to actually supply the chemical change, the hormonal change that they don't have with a band. Just because it's their option of not having more surgery, not that is the most effective. I think one of the things that we have to remember is that we surgeons, we don't touch more than 1% of the individuals who are eligible for surgery. And whatever we can do in order to address the obesity issue, I think we have to see with less prejudice than what we have, especially on patients who had previously bands. Not that I think we should restart putting bands, absolutely not. But I think we have to listen also to what the patient wants. In special occasions, have to work with them and find solutions for them that can be effective on the way that they can achieve some success in terms of treating obesity.
Okay. Thank you. There's a question here, and maybe Dr. Sohail can answer that. Why patients on GLP-1 should wait at least 1 week before elective surgery? What happens when patients need an urgent to emergent surgery?
Yeah, absolutely. So that's the recommendation by like all the national anesthesiology organizations, and it's because of the concern for the delay in gastric emptying that's caused by these medications. So pretty uniformly, they say to hold it for 1 week prior to surgery, and then they recommend anyone who's getting urgent or emergent surgery that's on these meds, they should be treated as if they have a full stomach. So they should get RSI.
Yeah, thank you, Dr. Swale. And when these medications first came out, and we do our own endoscopy, I noticed that several patients had food particles still in their stomachs, and I thought they had gastroparesis, and I sent them for gastric emptying studies and things like that, try to figure out what was going on, and then realized they were on GLP-1 drugs.
And I'm glad you bring that up, Ranjan, because actually the half-life of GLP-1 agonists is actually 6 weeks. And I think the ASA was being very conservative in saying 1 week. I think ideally you probably want to have the patient off the GLP-1 for 2 weeks, but then you run the risk of them regaining weight before surgery. The other thing is that we found that a lot of these patients' GERD symptoms increase as a result of the delayed gastric emptying as well.
Dr. Jayaraj?
Just one thing about that, Samir. We found a similar situation, but it's more related to how they are eating. If their behavioral doesn't change, that's when we see that. And I think this is the most important thing that we can do, is to establish the use of those medications with a comprehensive program where they're going to be not just overseen by the dietitian and the PA or the nurse practitioner, but the physician sometimes, where they can give really good orientation on reducing the meal size, spacing their meals, and doing it more slowly. People tend to eat very, very fast. And we see anecdotally that it makes a big difference when they eat too fast, too much. And when I say too much, it's too much for them. It's not just an individual plate.
Dr. Ross, you're a foregut surgeon. Have you seen effects with GERD with relationship to these drugs, or do you use these drugs in your practice at all?
I'm actually a foregut surgeon that doesn't do bariatrics.
Right. No, I just wondered if you're starting to see patients in your foregut practice that show up like with reflux symptoms, and the issue is really that they are on weight loss medications.
No, I haven't.
Yeah,
I haven't had any experience with that.
Yeah, so one of the recurring problems that we've seen is when I've done a duodenal switch or a gastric bypass in our patients, and they come with abdominal pain, and obviously we worry that they might have bowel obstruction. We CAT scan them, and the CAT scans are normal, and this has happened to me on a couple of different occasions. And when we dig a little bit deeper into their history, some of them have been taking additional GLP-1 drugs, and that's causing them their GI symptoms, and they're doing that to augment the effect of the weight loss that they're getting, either from their primary operation, or they were starting to get weight regain, went back on these medications through their primary care doctors, then developed the GI distress, and then showed up in the emergency room worried that they might have a bowel obstruction. Samer, have you seen some of that?
I haven't, but it's interesting to learn of your experience.
Yeah, interesting but random.
My question, question to the group is, I do see a lot of obese patients with very large paraesophageal hyaluronias, and they're sort of obviously that cannot be fixed with just a primary repair, and so you need to do a gastric bypass in those patients in addition. As a bridge to anything, a lot of them come in with, somebody trying weight loss with some of the meds that you're talking about. And Sarah, they all tend to have terrible, terrible reflux, in my opinion, at least in what we've seen. So what's your advice, Dr. Sahel, in a patient like that, where you don't have the luxury of waiting for the usual bariatric pathway because they can't swallow, or they've got an intermittent torsion, or something like that, and they're obese?
Yeah, good question. I think that's definitely a very challenging scenario. I think part of it would be kind of, as Dr. Podkameni suggested, is making sure that they're implementing like behavior modifications and lifestyle changes along with using the GLP agonist, to see if maybe if they're eating smaller meals, they could get a little bit more control of their GERD. But obviously as much weight loss as they can achieve preoperatively is going to help with the success of their paraesophageal hernia repair.
Yeah, and Dr. Benzie, you've been in clinic with me multiple times. What are your thoughts?
So the same, I think SAGE actually came out with a consensus or recommendation article while I was at the end of fellowship, and that was the major highlight in that article was, consider early gastric bypass in these patients because their recurrence rate is just astronomical. The challenge that I have in doing that in my own practice is that I'm not a bariatric surgeon. I don't have bariatric malpractice. I do have privileges technically for that operation. But I only do it in very limited circumstances. And a lot of the reason why is exactly what you mentioned, Dr. Sohail. It's really the behavioral modification follow-up lifestyle choices that is the most difficult to control in that patient population. However, if you're regurgitating all of your food, and you have nutritional deficiencies, vitamin deficiencies, despite a high BMI, I do agree. I think that's a good indication for an operation not for weight loss. And I document that very thoroughly, thanks to Dr. Dairaj's, training, but to actually improve quality of life in those patients. And I think that's a great adjunct too, is to make sure that those patients do have follow-up either with an obesity medicine program or actually ask a bariatric surgeon to come with me to the operating room and do that case together. And that's actually the route that I have been doing where I'm at. I do actually have a question for all the fellowship program directors on the call too. Given that all of this has been changing, what are the changes in our fellowship curriculum do you think that we need to start implementing going forward in order to make sure that our fellows, have the correct tools that they need, to address these situations between medical, surgical, or adjunctive management in their future careers?
Which situations are you referring to, Annie?
So those would be where now medical management of obesity has become more prominent, especially in those patients that would typically be seen in private practice versus those that come to academic centers. So I actually have a partner that is becoming employed from private for that reason, because a lot of the cash pay or privately insured patients are now choosing medical therapy first or in lieu of surgery.
Well, I don't know. I have Rohan here also. We're both at the Fellowship Council, and I can tell you, I think the ASMBS, which is the governing society for the bariatric surgery fellows, their curriculum specifically mentions that fellows should be trained in a whole, they should be exposed to the whole continuum of potential options. And I think any busy program is going to have the same, any fellow in any busy program in the country is going to have the same exposure as in situations that you describe. I don't know if we need to specifically modify the curriculum, which is a big deal, to address this one situation, but it's certainly something we need to keep in mind.
Thank you. And also for our international colleagues on the call, this was in the chat as well. What kind of experience do you have outside of the US? And while we're getting ready for that, everyone, can you please put your camera on, because I would like to take our Twitter picture. Any of our international colleagues? I see you, Dr. Marchand. Everyone else signed off. Okay.
Let me jump in there, Annie. I was at the GI Summit as were, I think Dr. Ross was there as well. And I had a conversation with a surgeon from Spain who does bariatric surgery there. And interestingly, these GLP-1 drugs, because of the socialized system of medicine, are a little bit more available there. And they are not that expensive, again, because the government covers for their provides coverage to their citizens on account of that. So I thought that that was pretty interesting. And they, just like us, are seeing a decline in the bariatric surgery numbers, at least initially, while people are trying out these medications. So that's the only perspective that I have. I thought that maybe these drugs are not quite so available, but indeed they are, and actually not that expensive.
Thank you very much for answering my question.
Yeah, and then I have another comment. I'm sorry, I'm jumping in here with regards to the gastric bypass question that you had, Annie. For the patients who've got big paraesophageal hernias and who are not able to go through their routine pathway because their insurance companies, for instance, may not approve bariatric surgery, we are still able to code the operation in a way, and I'm sure Dr. Jayaraja and you are familiar with it, but we're able to code it in such a way where we address primarily their reflux issues. But even though we are able to do the operation, the point that you mentioned, and that's the point that I wanted to highlight for the fellows, is extraordinarily important, which is the nutritional aspect of it. Patients after a gastric bypass will get dumping symptoms. Even though their reflux is better, they'll get nutritional deficiencies. And they need to be mindful of potential bowel obstructions down the road. So there is this whole pathway that is educational that still needs to happen, regardless of the fact that you can bypass the insurance requirements for them in the interest of their safety as well as yours.
Ranjan, I strongly, underscore the fact that you really have to spend a lot of time with these patients who are primarily coming to you for GERD and not weight control, because I've had a few of them who tend to be a little unhappy that they're having to make dramatic changes in their diet because of GERD, because this isn't what they primarily came for. They tend to resent that fact a little bit. So we have to be spending an extra amount of time and making sure that they understand that although this operation is going to be effective, there will be a lot of changes that need to be made. As for the CPT code, thank you, Rohan. But regardless of what I use, I find that I eventually come down to having to have a peer-to-peer or an appeal with the medical director of the insurance company. For some reason, anything that smells of a bypass triggers, a denial, an automatic denial, which has to be appealed.
Well, when it's coming from a world-famous bariatric surgeon, that's all they think you do, as opposed to Dr. Jayaraja, who's a world-famous complex GI surgeon.
So I do think we need to finish up. Hey, Dr. Benzie.
I agree. Well, thank you, everyone, for an amazing discussion. And thank you so much, Dr. Sohail, for a delightful presentation. We are back on February 26th next month with our next topic, which is management of IPMNs. And if everyone wouldn't mind just smiling for a second while I can get a good picture for our Twitter, formerly known as X. Ready? 1, 2, 3. Perfect. So again, thank you all. Have a great night, and I'll see you again next month.
Thanks, everybody.
Bye.
Great presentation.
Thank you. Thank you for inviting me. Thank you.
Thank you. Thank you.
Thank you.